Vice President of the Board. I am uh, currently your host today. We're going to be having some announcements initially from our community partners, but we are excited to talk about antimicrobial stewardship. Lauren Biehle from CDPHE has joined us today. We're kind of doing a two-part series on this. We're going to kind of continue this theme next month as well. And then we'll be going over the national highlights from the conference that was out in Anaheim, and then talking a little bit about our local conference that we'll be having in April, coming up very quickly. So it looks like Jenny, you are on if you would like to go ahead and give us updates from CHCA.
Absolutely. Thank you so much. I'll pop up the slideshow here. And you do have these slides through Dr. Palat for distribution in PDF format. The links will be live. All right. I have a little bit of complexity to relay to you, so bear with me. First off, payment rates. I know you all are engaging nationally in a battle to improve and gird against payment rate changes for physicians specifically, but you will also be impacted by the payment rate changes that are coming to nursing homes. There are three primary revenue streams that we rely upon, and all three of them are looking at having changes in fiscal year 2027, which begins in October as far as CMS's fiscal year. Medicare, they've announced, will increase by a 2.4%, which is extremely minimal. As I'm sure you know with your household budgets, that is inadequate to cover inflation. Our average inflation rate is typically 3% year to year, and it's even higher of recent years, as we're all well aware. And there's also an increase in labor competition requiring us to increase our wages every year. So 2.4% will not cover that. There is a potential also for legislation to be introduced this year again to pursue a staffing mandate. So even though that was rigorously fought and defeated, there is a new look at it coming from lawmakers. Medicaid also is going to experience at least an across the board cut of 2% to all Medicaid programs in the state of Colorado. And the final budget does have to be passed by July 1st for the fiscal year start. So we will know whether that is rock solid or increased shortly. This further disincentivizes us caring for this population in need. But the bottom line to all of this is that you're going to see your buildings increasingly looking at incoming admissions from a financial perspective, which I don't think any of us prefer. Because they're going to look at balancing how much can they afford for high cost meds, high cost care needs, wound dressings, etc. Managed care is looking at a similar increase to Medicare, but the clincher here is that managed care typically reimburses at a lower rate for us, does do pullbacks of money that they've paid us through auditing processes, and also CMS and legislators are looking at promoting a default enrollment in managed care to essentially eliminate regular Medicare in our population, especially. So all of these are pretty threatening to our bottom line. We'll just have to see what happens. Antipsychotics has been on the radar for quite a while. I want you all to be aware that they have changed. CMS has changed how they are looking at antipsychotics. It is one of our quality measures that flags for surveyors to look at when they come in, and it can reduce our payment if we have inappropriate use of antipsychotics in our buildings. CMS thought that it was inaccurately capturing the antipsychotic use in our buildings because MDSs, as you know, they're the assessments that capture the care we're giving. They do not capture managed care patients. And so without that, and with an increased saturation of managed care in our buildings, we essentially were carving out an entire population. They have recently added the ability to look at antipsychotic use from pharmacy claims data, meds filled while the person is a resident, which is the primary change that they've made to bypass this issue. There's also a look at making MDSs a lot more thorough for every person in the building rather than based upon pay status. The main takeaway for you all is to ensure that you're discontinuing antipsychotic use timely to prevent unnecessary med fills, since it will automatically make them flag as using the med if it is filled by the pharmacy. From our perspective, antipsychotic use, I think for all of us, smacks of polypharmacy oftentimes or inadequate behavioral interventions. And so I just want to clarify where we stand in Colorado. We have seen a 2% jump in the quality measure for antipsychotic use since they changed the way they capture the data. So that is going to look a little extreme. But we do actually have overuse in our state. We exceed the national average by 4%. And 32 of our 210 SNFs do use 30% or higher antipsychotic in our long stay residents. So that's pretty significant. Some of our buildings are as high as almost 73% use of antipsychotics. It's too high. Bottom line, it's inappropriate, and all of us bear the burden of trying to reduce it. And then just a couple of reminders here. This is linked on my blog as well, but this is the blog reposted for your reference. Advanced directives are often inappropriately used, and we just recently experienced an immediate jeopardy citation for people using CPR when they ought not to, and vice versa, based on how the facility operations was communicating advanced directives. Timeliness of physician signatures, et cetera, was all at issue. And so I put this here as a point of reference. Quick note, the most form is not required. I think most of us know that, but this goes into greater detail. And then because people ask me periodically whether you all are seeing an increase in medical director tags since they updated all of the citation rules around medical director responsibilities. F871 is your particular special one. It has not been cited a single time in Colorado since 2024. So far, so good, although you are under scrutiny through the QAPI process and so forth. There was one citation in 2024 for physician visits being inappropriately infrequent, I suppose. All right, that's it. Thank you.
Thank you, Jenny. I don't know how you keep up with all the Medicare, Medicaid changes, so I'm really grateful for you being part of these meetings every month because you always have really good details to share with everyone. So, all right. I do believe Chad Fear joined us. Chad, are you available to give us some updates from CDPHE?
I am. Can you hear me?
Sure can.
Oh, it's magic when the stuff works. Yeah, just a few more updates. And I would thank Jenny. Those are great statistics, and I think something for us to be taking a look at. And I mean from the surveyor side, we seek to understand. And there might be instances where we might be considering the quality assurance. Is an issue with quality assurance associated with the deficient practice? Is it the activities of the medical director? And it's been many years, I think, since we've had an actual medical director citation. And I think it's because we try to understand the circumstance and to really, if we have to cite something, keep it with the actual care, the direct care being provided to the individual. It's just when we start to see systems or lack of oversight that we have to start looking at other areas, administration and whatnot. So I think we do have a little bit of a different perspective on that than maybe is shared nationwide when it comes to the leadership of facilities. Updates for us. It's springtime, so that means we're going to have to be filling some positions. We seem to have some folks move on and move around about this time of year, and this year will not be any different. So we'll be doing that here shortly. Jenny mentioned some immediate jeopardies, and I'll just mention the immediate jeopardies since the last time we met. We had a failure to address a significant change of condition. There was an unavoidable injury during transportation, and then life safety cited an immediate jeopardy related to not maintaining smoke compartments. So from the last time we met, those are the updates for that. We're going through a lot of, I think, transition nationally. In terms of incorporating guidance, there were updates to the State Operations Manual, Chapter 5, which is our guidance around complaints and facility reported incidents, as well as Chapter 7, which is enforcement, although it's more than enforcement now. way back when, before we started doing a ton of revisions to the state operations manual back in 2017, 2015, 2017, and 2019. Were when a lot of everything was rewritten. And at that time, we were following a survey process, ASEQ. So this was built out of the quality indicator survey process. Along with that, we had Appendix P. Appendix P told us how to do surveys. Well, when we changed through all of that process, they did not rewrite or reissue Appendix P. So a lot of what we did in terms of survey, we did based on muscle memory. The new update, which will be effective at some point this month, is they've included guidance for survey along with Chapter 7. So we do have some new guidance back, and it talks to things like team composition, which is not as big of an issue for us. Some states only have nurse surveyors. So that makes it very difficult for them to have a multidisciplinary approach for their survey teams. It's creating a lot of angst, quite frankly, for a number of states. It also provides guidance around survey length and other survey expectations that are not included directly in the survey software. One such thing, and I'll go back to the survey length. The requirement has been for some time that we have to do recertification surveys in 4 consecutive days. It's impossible for us to meet our workload starting a survey every Monday, right? Or if we started a Tuesday, we'd have to work through Friday, but it has to be 4 consecutive days. I think CMS has heard us and is going to be looking at changing that, which is going to allow us, and the requirement we believe is now going to be 2 consecutive days, which means, and you may remember some years ago when we were fully staffed, we were able to start some of our surveys on a Wednesday. So we'd do Wednesday, Thursday, Monday, Tuesday, or maybe it was the traditional Monday through Thursday based on 4-day work weeks. This should allow us to conduct more surveys more frequently, and certainly with the full intention of resolving, I'll call it a backlog. I've avoided that term for a little while. I wanted to just call them overdue, but it's really resulted in a backlog. And by being able to do more surveys per month, it will allow us to bring all of your facilities up to date, which we know is very important when you look at a whole bunch of other factors, including your star ratings. So we certainly want to be compliant with that, and this move is going to allow us to do that. The other piece to this is they have also aligned complaints with this strategy. It was actually the first strategy, and then they aligned the research with that. But if a complaint takes more than 1 day, that second day has to be a consecutive day. So we're going to we try to manage that with scheduling and whatnot. But what we will have is situations where if a complaint is open on a Thursday and it cannot be exited, that surveyor will have to be back on that Friday. Whereas I think traditionally we've been more flexible in terms of where the weekend falls and how the work week has operated. So just to kind of throw that out for you all, you're going to see us more, I hope. And with our efforts to hire, I hope there's more of us to see. And we certainly want to be able to resolve whatever backlogs we have so that, we're working in current time and really, in step with y'all.
Thanks, Chad. That's great. I think all of us can empathize with staffing needs and being short-staffed and needing extra help. So that sounds like
Certainly.
a lot to juggle, and I hope that it works out for your team to make that a little easier for you all. So, all right. Well, thank you so much. All right, we will move on. Like I said, Lauren Biehle, who is a PharmD and a CDP, she is the head of the Antimicrobial Stewardship Pharmacy Lead at CDPHE. She is going to be talking to us today about what is new in antimicrobial antimicrobial stewardship in our setting. So welcome to our meeting, Lauren. And would you like to share your slides or would
Sure.
you like me?
Yeah, I can. Let me make sure I can
Okay,
share. All right. Hopefully you guys can see that. I'll put it in slideshow mode.
perfect.
Okay, great. Well, thank you so much for having me, Rebecca. Thank you for the introduction. It's always great to see all of you. And when I was thinking about antimicrobial stewardship, like you mentioned, this is a two-part series. But my thought was, what's new? What's changing in practice? What could, what new studies are out that could affect what you do every day? So that's really the focus of this presentation. I'll hit on the key components and best practices of stewardship, but I wanted to take a look at the data from 2025, 2026, and see what's new. So again, we'll talk about key components, core element implementation, and then tools and resources that are available, including some of our training opportunities at CDPHE, which I know some of you have attended. All right, so as we know, this data has been around for a while that up to 70% of nursing home residents receive antibiotics in a year. Up to 75% of those may be prescribed incorrectly. But there's some newer interesting data that nearly 10% of nursing home residents receive an antibiotic on a given day, and as many as a fourth of them have an antibiotic-resistant infection, which probably isn't that surprising if you take a look at a lot of the infection data. We have 7 core elements in stewardship. We'll briefly touch on each of these: leadership, commitment, accountability, drug expertise, action tracking, reporting, and education. So what is antimicrobial stewardship? The set of commitment and actions designed to optimize the treatment of infections while reducing adverse events associated with antibiotic use. There are benefits in multiple areas. In the individual patient or resident level, there's improved outcomes with fewer adverse events. In the quality of care level, there's lower rates of C. diff and fewer infections and infection-related deaths. And in public health, why we're interested at CDPHE is reducing antibiotic resistance and advancing equitable access to healthcare. I wanted to include some resources that you may not have seen or were recently updated. So this is from the ARPSP, which is the Antibiotic Resistance and Patient Safety portal from CDC. There's quite a few different data sets on there, including these maps, and there's information on outpatient antibiotic use, inpatient. If you want to look at things like the median income in Colorado and demographics, all of that's on there. So this is looking state by state at how many of the long-term care facilities have implemented all 7 of those core elements that I mentioned. The data is from 2024. So for Colorado, we're right at 80%. And I'll note that these data are from the NHSN Patient Safety Survey, which isn't required. So the 80% of those meeting all 7 core elements is represented from 57 facilities in our state. They even break it down by individual core element, which I love because we do our own internal analysis, but it's really nice that it's publicly available too. So as I mentioned, we have 80% for meeting all 7 core elements. And of those 57 who reported, 100% of them have leadership commitment, action and tracking implemented, and then it's slightly lower, but still all above 90% for accountability, drug expertise, reporting, and education. I also think it's helpful to take a look. I know Jenny does such a great job talking about trends in her data. I pulled from directly the CMS data set, the citations in Colorado nursing homes 2024 and 2025 that were related to infection control. There were 199 total. 157 of those were providing and implementing an infection prevention and control program. And the next one down would be the 17, which is implement a program that monitors antibiotic use, which of course I'm interested in for stewardship. And you can see the others on here are related to things like vaccines and having a qualified infection preventionist. One of the studies that just came out is out of Utah. So our neighbors, they sent a cross-sectional survey to their nursing homes. Their response rate was 50%. They found that most facilities, about 96%, reported leadership support and at least one facility policy to improve their stewardship program. About a third of nursing homes didn't have infectious disease experts. And a majority of facilities, 69%, did report the use of treatment protocols and algorithms. So those was interesting studies. I always like to see when states come out with their data around core elements. Like I said, we evaluate ours in Colorado every year as well. And I'll highlight one of the other findings that they had around the leadership of stewardship programs as well. So our first core element is leadership and accountability. So these include things like statements in support of improving antibiotic use, stewardship duties and job descriptions, empowering and engaging leadership, and communicating facility expectations. There are posters and commitment letters. I took the screenshot of the top half of one here on this slide that are available through CDC. This is from that Utah study. I always like to see who is leading stewardship programs. It's something that I evaluate for who's attending our sessions at CDPHE. So I'm curious who is leading those. And in data from Colorado and Washington, over 80% of the time, that's the infection preventionist. So I thought it was interesting that in this Utah data set, they were listed as the majority, or the highest percentage was 37% as the director of nursing and ADON, followed by the infection preventionist at about 22%. But then at the same level, infection preventionist was also unknown. So it's a pretty interesting breakdown of looking to see who by facility report is accountable for stewardship at that level. The other thing that's come out recently that I see something in the chat. Let's see. Oh, nice. Okay, so Jenny says we receive an immense boost in participation from our Pay for Performance program, which incorporates the core elements. Yes, absolutely. Thank you, Jenny. That is a great segue. I'm going to be talking about that. So yeah, thank you for mentioning it. That's fantastic. I love that it incorporates the core elements as well. I think when we are planning programming around stewardship, we often think about knowledge. Do they have the knowledge about whatever the topic is? But so much of stewardship is behavior change, and that comes from a different area of science than just knowledge alone. So this study just came out this year looking at behavioral determinants in antibiotic prescribing, specifically around UTI in nursing homes. So there's more quotes in the article if you're interested. But the way I organize the table is the first column is domain, second is behavioral determinant, and the third one is a quote from this qualitative study. So I'll just highlight a couple of those. One is knowledge, so knowledge of guidelines. The person they interviewed said, I don't think we know the scientific guidelines. I don't anyway. Another one is about fear of missing complications in our vulnerable population, feeling powerless, so maybe they can't change the antibiotic prescribing themselves. And then that social pressure to prescribe. So family members coming in, being compelling, and then the person ends with saying, and they can also pressure doctors very forcefully. So I thought this was really great, a really interesting qualitative analysis that, again, I can send it to you if you're interested. The citation is there. We also had a presentation in the fall from Dr. Alyssa Castillo out of university around productive conversations in stewardship. Because again, it's not just knowledge, it's how you have these conversations around behavior change. And so she highlighted that behavioral change in stewardship can be challenging if three things: values aren't aligned, there's a difference in training and expertise, which we've definitely, you've probably experienced, I've experienced for sure. And then habits are deeply rooted. And so those three together make it difficult to have conversations around behavioral change and stewardship. So she has a framework of advocacy, inquiry, listening, and teaching. And she has a whole presentation on this, but essentially the first step in advocacy is coming in with an objective question. Inquiry, asking open-ended questions. Have you considered things like that? Listening to the response. And then if you disagree or you would prefer to go a different direction, teaching why. What the latest data shows, what the guidelines say, things like that. So she has a really great talk on this. And again, I just think it goes outside of just knowledge and, can you recite the guidelines to how do you implement that behavior change? The next core element is drug and pharmacy expertise. So working with a consultant pharmacist who has training in stewardship. The CDC has free training. There's definitely training out there. They can help develop guidelines, track antibiotic use, provide education, and collaborate with infectious disease consultants. If you have a new pharmacist in this field who is a little unsure of their role, the CDC has this 5 ways consultant pharmacists can be antibiotics aware that are specific to the nursing home setting. So they include things like fluoroquinolone use, UTIs, things of that nature. We'll spend quite a bit of time on action because there's so much involved, but it's implementing prescribing policies that support appropriate antibiotic use. We definitely recommend starting small. I know in one-on-ones with our nursing homes, it can seem overwhelming, and IPRD has so much on their plate, or whoever is running the stewardship program. And so starting small with a stepwise approach to address an issue specific to their building. So what is specifically, is it a wound issue? Is it a duration issue? Is it a UTI issue? Things like that. And so this could be things like including facility-specific treatment guidelines for common infections, diagnostic stewardship, antibiotic timeouts. I'll highlight some of our tools from CDPHE. On this slide, we have the antibiotic timeout checklist and our UTI action tool, which I'll cover a little bit more in a few minutes. This study was interesting. It just came out last year, and the data is from 2018, 2019. So keep that in mind. This is pre-COVID data, but they looked at data from CMS to see if residents were prescribed an antibiotic when they were in a nursing home and the most frequently prescribed. So in 2019, over 186,000 residents were prescribed an antibiotic, with cephalosporins being the most common at 26%. The average duration of use was 9 days. And one finding they had that I thought was interesting is that residents who were dually eligible for Medicare and Medicaid had a 37% increased odds of receiving the antibiotic. So I just thought that was an interesting finding because it was pretty high. This is a chart they had in that paper. And so you can see cephalosporins at the very top in purple at 26%, followed by quinolones, penicillins, and tetracyclines. One of the things, as mentioned in that behavioral change table, but just in general, that we're all concerned about is an infection going to lead to hospitalization? And so this was an article that just came out this year, came out a couple weeks ago, about incidents and factors associated with hospitalization for UTI in nursing home residents. And so this is based in Australia, so not exactly applicable to us, but I still thought it was interesting. It was an evaluation of the incidence of hospitalization for UTI in long-term care facility residents within their first year in the facility. So what caused them to go in the first year? And it was between 2015 and 2018, included over 180,000 people. They found a cumulative incidence of hospitalization for UTI in the first year of about 3.7%. And what I was interested in is what were the factors that contributed to hospitalization? What did the people who were hospitalized, what did they have in common? And there was a long list of factors, but what I thought was interesting was long-term catheter use with a hazard ratio of 3.39, history of hospitalization for UTI with a hazard ratio of 2.33, and receipt of antibiotics for UTI treatment and or prophylaxis with a hazard ratio of 1.41. Going along the UTI train, this is our UTI action tool. I know I've talked about on this call before and in others. And so it's a quick checklist meant to be done at the bedside that follows lobe criteria for evaluating whether or not a resident has criteria for a suspected UTI versus asymptomatic bacteria. As a reminder, we do have a guideline summary available on our website at CDPHE. This is just a snapshot of, for example, the skin and soft tissue infection section. So these are not CDPHE guidelines, like we did not come up with these. They're a summary of available guidance. And so this comes from the IDSA guidelines by Stevens and Dr. Robin Jump's recommendations from a 2018 paper. And so, for example, it has the type of infection, description, treatment, duration, and citation. So these are available for skin and soft tissue infection, UTI, and pneumonia, and it includes their lobe criteria as well. Of course, we have to talk about First Line up. First Line is supported by CDPHE. I know some people have contacted me about accessing First Line because it's not nursing home specific. The guidelines that are within this app are Children's Hospital and also Denver Health. So it is meant to be used in all clinical settings. And so the adult option would be Denver Health. And if you're not familiar with First Line, these are stewardship specific guidelines in a free app. That again, like I mentioned, CDPHE supports, and the guidelines themselves are developed by Children's Hospital and Denver Health. Last thing I wanted to touch on within action is kind of a preview as well of my talk that I'll be giving later this month, but talking about urinary diagnostics. So within our Choosing Wisely guide around actions, we have don't obtain urine tests until clinical criteria are met, and don't utilize molecular testing to replace urine culture for diagnosing and determining treatment for UTI. This is a recent addition, as well as the PALTC consensus statement. So this 2025 consensus statement is on the use of urine PCR testing for UTIs, and it was authored by Dr. Zaring and Dr. Ashraf on behalf of PaltMed. So let's see. Oh, thanks, Sing. They recommend against the routine use of urine PCR for the diagnosis of UTI. A couple of quotes from their very concise consensus statement is the evidence supporting urine PCR is often biased because of funding sources, and there's no objective evidence of patient benefit. Urine PCR testing likely will lead to unnecessary antibiotic use, which drives antimicrobial resistance. So both Choosing Wisely and the PaltMed consensus statement are new for 2025. The consensus statement also states that an antimicrobial stewardship program should use the CDC core elements for nursing homes to engage with a multidisciplinary team when making decisions on urine testing. And this consensus statement was endorsed by SHEA, APIC, and the American Association of Post-Acute Care Nursing. We also have a wall chart at CDPHE that just has a comparison. It's meant to be, it's a one-pager for staff and others that compares urine culture and rapid diagnostics like PCR with how they work, their benefits, their limitations, and their role in antimicrobial stewardship. Moving into tracking, we have the importance of tracking is that monitoring antibiotic use and outcomes includes things like tracking antibiotic starts, days of therapy. There's options to do point prevalence surveys, so once a week, and tracking outcomes of antibiotics with things like allergic reactions and rates of C. diff. In our evaluation of Colorado core elements, it appears that most tracking is done in the infection control log. That's one of the options in the NHSN survey. So that seems to be the major way that tracking is done in our state. I did want to mention we do have this tracker. Someone had mentioned last time that maybe one of the formulas was giving them trouble, but this is a Google Sheets tracker that you can use in Sheets or Excel, where you enter in the data on indication, class, prescriber, and time frame, and it'll create graphs and visuals for you to use for things like QAPI or other meetings. Moving into reporting, I just wanted to touch on the antibiogram. I know I've talked about with this group, so I'm not going to spend a ton of time, but we do have a quick guide to antibiograms on our CDPHE Stewardship and Long-Term Care website. So if you are working to create an antibiogram, we have a one-pager for explanation of the role of an antibiogram and what should be included. We also have our Colorado Nursing Home Antibiogram, which is the report of 2023 antibiotic resistance data by 196 long-term care facilities. I've just included a snapshot of that here. Since the vast majority, over 90% of isolates were urine, that's primarily a gram-negative antibiogram. And so that's broken down by organism, number of isolates tested, and percentage susceptibility to each drug. The final core element is education. So stewardship education to clinicians, nursing staff, residents, and families. We do have some options available on our website for communication. I personally love the one about talking with residents and family members about UTIs. That is an AHRQ resource that I think is fantastic. It has scripting for talking with family members about what they're seeing and about the prevalence of asymptomatic bacteriuria. And then CDC, of course, also has flyers as well. Some of the resources I talked about today are things like the core elements for nursing homes, our CDPHE, Antimicrobial Stewardship and Long-Term Care website, that guideline summary, and then as I mentioned, that first line app, which is a no-class app. You can have it on your desktop or your mobile device with adult and pediatric pathways. And then just want to highlight a few training opportunities that we have coming up. So some of you have joined for our case LTC. Thank you for joining for that. That is a quarterly live virtual series where we have a discussion forum on a certain topic. We've covered UTIs, we've covered antibiotic selection and duration, and next up we're planning to discuss diagnostic stewardship. So anyone's invited who participates in antimicrobial stewardship at their facility. Our next one is quarterly, so our next one will be in June. Beginning in 2025, CDPHE began offering infection prevention and antimicrobial stewardship training associated with pay for performance. Thank you, Jenny, as I mentioned, for the segue earlier. So we presented it twice last year. We had over 200 participants, and so we're planning to repeat that again this year. It's a 90-minute overview of the infection prevention ICAR modules, catheter-associated UTI, and antimicrobial stewardship. So those are planned for June and October, and we're updating that content based on participant feedback with more things on, enhanced barrier precaution and other topics desired by the audience. And then we are going to be initiating our Tag Buster series again. So this was our 4-month quality improvement initiative, and we're going to be focusing on antimicrobial stewardship, UTIs, and drug regimen review. And so CDPHE is going to be hosting that in partnership with Telegen. So we're really excited about that. That'll be again later in 2026. So with that, I'm happy to take any questions, but I appreciate it. Hopefully some of those updates will be helpful to you. And again, I'm happy to expand on any of that, and I'll add my contact information in the chat as well. Thanks.
Thank you so much, Dr. Biehle. I feel like every time you guys present, there's just more and more resources that you make available. And I know myself, I will be tracking down the Google Sheet tracker for use. So I really appreciate that. It's stuff we can go and use right away. Does anyone have any questions? We'll give the awkward pause, make sure we leave time. All right. Well, good. Well, thank you so much. We really appreciate your time today.
Thank you.
All right. Next up, Dr. Palat is going to be presenting about some of the highlights from the Anaheim conference that we were recently at in California. It was really fun to see everyone. But before she starts, I have to just offer congratulations to Dr. Palat. She was the recipient of the James Petit Award for Excellence in Education, and it's well deserved for all the work that she does for our organization. And we just have tremendous leadership in Colorado, and she's definitely part of that. Also want to, give a shout out to Dr. Eber, who was inducted as the current president for the National Society as well. So we are super lucky in this state to have such wonderful leadership in the post-acute space. So, all right, I'm done bragging about you, Dr. Palat. I'll turn it over to you.
Well, thank you, Dr. Jackson. And I'm so glad that we got to spend some time together last week at this conference. This is the post-acute long-term care conference that's held every year. This year it was in Anaheim, California. And today I'm joined by my colleagues, Andrew Grossman and Chikal Patel, who are from the Washington State chapter of PulpMed. We're the Colorado chapter. They're from Washington, but we are also colleagues together at work at Optum. And we put together a small little slide set with some of our favorite highlights from the conference. And I think that we'll try to get through this so that we have a few minutes at the end to invite anyone from the audience who was at the conference to also share any pearls of wisdom you have for the audience for teaching purposes. And the reason that we want to do this, of course, is to share this information from our national conference, but also to remind you that we're having our local conference in Colorado coming up on April 24th. So don't forget to go to the website, cmda.us, and get yourself registered so that you have a spot, and I can order you some food for this conference that's coming up on April 24th. So Andrew, thanks for joining us. Would you like to start?
Yeah, thank you. Yeah, and nice to meet you, Rebecca, there at the conference as well. Yeah, so I have 3 slides here. Wait, there we go. So this the first slide, it's actually a twofer. So I wanted to present on 2 lectures. One was navigating the CMS regulations in long-term care psychiatry. And this they were recognizing just with the current CMS measures, They treat appropriate and inappropriate antipsychotic use equally, leading to treatment gaps, substitution issues, like using lots of other classes of medications like excessive antidepressants, anti-epileptics, analgesics, and just those issues combined leading to increased safety risks, which we're trying to reduce with why these measures are there in the first place. So they had two recommendations. One just for navigating the current environment, communicating behaviors amongst the IDT, making sure everyone's seeing the same things, behaviors are being documented, treatment goals are being aligned. And then they were kind of advocating for this coalition pause, which itself is advocating for evidence-based practices in regulatory frameworks, including reducing punitive measures to SNFs. But they noted good documentation is still going to be needed. Some of those, this is a coalition that's itself interdisciplinary. So it includes like the Alliance for Aging Research, or an ASCP for psychopharm, AAGP psychiatry, and Leading Age. Do you guys have Leading Age out there?
We do, yeah.
Okay, all right, okay. Yeah, so focuses on providers of nursing homes, I think, and maybe assisted living too. So if you want to join the cause, please do through any of those agencies. Second one, interdisciplinary approaches to advanced care planning. These were two palliative care providers. This was some familiar topic, but I appreciated their approach. They were talking about late referrals or interventions of palliative care versus early ones. So the late model tends to, I think I updated this, but leads to the hero model, which can be leading to more crisis mode, reactive, can be very emotional and unpredictable, versus the systematic model, which has defined triggers, standardized review and documentation, and is generally more reliable, but maybe a little more boring, but requires structure and less heroics. They did note the heroics are still going to be needed, and they can feel good, but it's not ideal. It just leads to stress, and that hero is not always available. So next slide. Oh, so this by Dr. Sandeep Patel was a review and going deep into the BMP. It really could have been like a 90-minute lecture, but he was really smushed into about 15 to 20 minutes, I think. So I just wanted to give some takeaways or some handouts. He had some nice tables on just a reminder of electrolyte effects of some common classes of medications here. So diuretics, psychotropics, and then steroids. So I'm not going to really say much more about this slide, but I thought it was a nice reference. And if you have a chance to see Dr. Sandeep for maybe a longer lecture, I'd recommend it. He was a very animated educator. All right, and then finally, sorry, I updated this one a lot. That's all right. But I presented, so this is a little call out to my own poster that I presented. So on advancing education and advanced care planning discussions for clinicians in nursing homes. And so our objective for about third of the year, half of the year last year, we did a number of mini sessions, and we were hoping to increase the confidence of clinicians' ability to present ACP discussions and then documentation. So we have about 40, mainly NPs, some PAs. And so we broke them into groups of about 4 or 5. And they've all been trained already in palliative care discussions, mainly grounded in vital talks. So we surveyed and came up with 3 different trainings, 30-minute trainings and discussions. One on the why of advanced care planning discussions, talking about all the potential benefits to all the different parties involved, whether at the facility level, patient, family, and also for the clinicians themselves. A second training on documentation, focusing on detailing the goals, specifying frailty and prognosis, and other and clarifying contingency plans. And the last one was just on challenging cases and kind of a systematic approach to approaching those, I guess. So there was I tried to do a pre and post surveying and various different methods. I did not do statistical analysis, but there was good improvement or some significant improvement to confidence as well as quality and so enthusiasm in general for having advanced care planning discussions. We'll say about 75% strongly supported additional volunteer or would volunteer for additional education. There were one or two that was like, I've had enough, and a couple that were neutral, but vast majority were very enthusiastic for more. So I will say, if there's always opportunity for more advanced care planning discussion, education. So I think that was one of my biggest takeaways.
Yeah, terrific. And I think Andrew didn't even include this poster in our original slide set, but I insist because thank you, Andrew, for doing this education for nurse practitioners in the first place, but also tracking the outcomes and putting them on a poster to share at a national conference. And so next year's national conference, if any of you want to respond to the call for abstracts, do it. You don't have to be a medical director to be part of this conference. Yeah, great work, Andrew.
Yeah, and I learned a lot doing it. So definitely encourage others.
Wonderful to hear that. Yeah. I'll share a few slides too. Think Before You Order was a presentation given by a couple of my colleagues and myself. And the premises was to get clinicians to think about the lab tests and diagnostics before we ordered them. And one of the highlights was this study about the abdominal X-ray or plain abdominal radiographs, which in this study were concluded to remain a low sensitivity test, looking at all comers to the emergency department with GI symptoms. 57% of abdominal X-rays in one study detected no abnormalities. 42% of those patients had further imaging anyways, and the plain films correlated with further imaging in only 15% of cases. So therefore, the abdominal X-rays are not sensitive for detecting acute pathology. They shouldn't be used to decide if a patient requires further imaging or a full clinical assessment. Essentially, if your history, if your physical is telling you that the patient needs a CT scan, or if you're wondering if you should go to the bedside and see them, go do that. The X-ray doesn't help make that decision for you. As part of that same talk, we talked about the brain type natriuretic peptide, the BNP. Just because you see an elevated BNP does not mean your patient has heart failure. On this slide are a list of many, many reasons that there can be an elevated BNP. You can have it from heart failure. You can also have it from a heart attack or from AFib. It can also be due to advancing age, anemia, renal failure, sleep apnea. People who are taking Entresto or sacubitril valsartan can have an elevated BNP. And if your patient has had a snake bite, you could have a BNP because there are certain venoms that elevate the BNP. So watch for that. And one of the most impactful sessions I went to was conducted by Chaplain Alex Donovan here from Colorado. And she talked about narrative medicine. There was this very powerful exercise. She put this picture up on the screen and gave everyone in the audience just 3 minutes to write down whatever you wanted on your little piece of paper, your little notebook that she handed out to us. Write down whatever you see on this picture. And I found those 3 minutes very relaxing and calm, but the real learning began after the 3 minutes when people were invited to share what they had written down. And that's when I started to really appreciate that I need to have really good skills about looking at details as well as the bigger picture, about appreciating nuances, and also appreciating various perspectives. And I think that sharing part was very powerful, and it also just made me think about my own bedside skills. So if you're looking for an exercise or some strategies to build up your teams and to connect with people while building bedside skills, think about narrative medicine. And now I'll turn to Dr. Patel.
Thank you, Dr. Palat and Andrew. So the conference was full of, great presentations, workshops, and I think that, all of you, right, those of you who were at the conference, must have found like your own few like favorites, right? So this is my list, and it is really not inclusive because I was not able to be there at two like presentations at the same time. So, I'm just, so I just have my short list over here. But yeah, if you have a chance to look at the presentations, if you have been able to buy the recordings, I think that was, that is also going to be a very good investment. I think something that they did like this year was focus on the clinical hits, which they are going to be doing every year. And so they focused on the chronic illnesses, on like every day there was a focus on like, every a few of the common chronic diseases that we encounter day to day. So I think that was really helpful. Yeah, so just a few things about the annual offerings. All of you may be familiar with the Futures program. Introduces early career or the prospective clinicians to post-acute long-term care. It provides an intensive one-day session at the conference, providing mentorship, networking, and also education. It is very well received. I wish I had the opportunity, when I was joining post-acute long-term care, and I think that this is really a great program. So if you have any medical students, any of your NPs, any of your colleagues who are PAs who are really early career and they want to know about post-acute long-term care, I think ask them to apply for this program. And then we have the leadership fellowship, for which I was the first part of the first cohort last year. I know that Andrew and Rebecca, you are now part of the second cohort this year. So that is just about a year-long commitment where you learn about the organization, about the board, how it works, and then you come up with a project that aligns with the strategic plan to support the growth and development of the organization. So, and I think that next year hopefully we can. I look forward to seeing what you guys come up with, what your cohort comes up with. So. And then again, call for abstracts for a presentation and workshop opens up sometime in July. So the date is not out yet, but that's the time frame. And then call for abstracts for posters opens up sometime, I think end of September, October, something like that. So yeah, just like look out for those. Next slide, please. So the keynote speaker was Dr. Dave Logan, and he talked about tribal leadership. And stage one is life sucks, and which is a mindset which is hopeless and hostile and seen in toxic environments. And of course, the behavior is more like sabotaging, disengagement, and the goal is to, of course, move them from that stage and move them forward. Stage two is, my life sucks. So, victim mindset, right? Seen and burned out employees, disengaged staff, minimal effort, apathy. So leadership move is, give small wins and build more of a personal tribe, right? Acknowledging them for their achievements. Again, pulling them out of that and really, finding, their why and to really engaging them. Step three is I'm great and you are not, which according to the book is like 50% of the workplaces have this mindset as individual achievement. Everyone is focused on their own achievement, seen as competition, working in silos, lots of politics going around, ego-driven success. So, of course, the shift is from me to we. So moving them to stage 4 and stage 5. Stage 4 is we are great, which is a sign of high-performing team, shared values, collaboration. It builds trust, innovation, strong culture. And then, of course, stage 5 is, where all of us, should thrive to be. But yeah, stage 4 is equally great. So stage 5 is life is great, is seen, rare. 2% of the teams have this mindset. It is purpose-driven, making a difference, world-changing teams. And then again, teams are focused on impact, not just success. So I think this is where our post-acute long-term care organization is. So next slide, please. Yeah, I wanted to talk about the PharmD Ethics Toolkit, which was put forward by members of the Ethics Committee. and you can find it on the PubMed website. If you just type in ethics toolkit, and you will see all the resources. So yeah, it's just a great resource, and it's a great framework for clinical ethics, and then also ethical problem solving in the post-acute long-term care setting. So check it out. Right. And Dr. Sinha's lecture, he is a geriatrician from NIA Canada, and I found it really good. Of course, there were a few other AI-driven lectures at the conference. I was not able to attend those, but however, I felt that this one provided me a lot of information about AI use in long-term care. Where does AI stand? And it turns out that we are not ready for AI yet. And many of the older adults, 46% said that they do not trust AI. There was some review of like 31 articles, and there was some mixed evidence in terms of effectiveness across different health outcomes. There's a high risk of bias. Of course, AI, can be helpful with medication reminders, orientation cues. At the same time, there's always a concern for privacy risk, dementia, and behavior symptoms. One example that he gave was like really powerful for me, that, what if someone with like behavior symptoms, dementia, is telling their like AI robot that I feel that this person is like trying to hurt me, and then what kind of a response is that AI robot going to give the member back? Is it going to say that, yeah, you should also hurt that person then? And right, so that was also again raising some issues. So safeguarding issues, consent and cost. So not quite ready for prime time yet, but next slide,
Chikal, I'll
please.
add that our Colorado conference has a presentation on artificial intelligence from a local expert, David Ginsberg. So that'll be interesting to see his take on it and his advice for us too.
Absolutely. Yeah. I think that there's like so much out there, and it's really hard to really understand, right? Like where what the need is, and like how much helpful it is going to be. So thank you. Sorry, you were saying something.
Yeah, for the sake of time, can we split through the rest of them and get to the end? Is that okay?
Yes, sure.
To see if anyone else in the audience had any pearls from the conference too. So these are really great messages, and if you didn't go to the conference, you should have gone, and you should try to catch up. Okay. And you should have come to our Colorado reception. We could have taken more pictures. This is all I have. We had a good time, and I want to encourage everyone to come to the Colorado conference, and you can register on our website, cmda.us. Did anyone else who attend the conference have anything to share?
I would say the pearl that kind of rocked my world was they did a sleep discussion, and the AGS has actually recommended doxepin as the first line for insomnia over trazodone, which I just, as a geriatrician, was fascinating to me. So neither is really an approved sleep aid, but they felt like low-dose doxepin had lower risk of orthostasis, falls, had fewer anticholinergic effects, and less next-day sedation. So that was the pearl that just kind of surprised me.
Watch out, might start being prescribed more here.
I know, that was weird. It was very interesting, though.
Yeah.
And there is a live stream option for the conference, y'all. So if you cannot join us in person, we'd love to see you, but there's a live stream option if you aren't able to make it. And we'd love to have you online as well. So thank you so much for joining us today, everyone. We appreciate you and all the work you do. Have a good day.
Thank you.
Thank you.